Dr. Soumyava Basu from LVTI, and he would be speaking on what to test and how much to believe. When I was preparing for my presentation, I had gone through a lot of his articles on ocular TB, and that had helped me a lot. And see, he has a very huge experience on how to do interpretation of these tests. Over to you, Dr. Basu.
Thank you very much, and thanks AIOC for this opportunity. Now, what I'm going to talk in this short duration is probably what you have heard in the previous 3 talks. I'm probably going to use a different language when expressing the same thoughts. So, 5 points. Why do we test in uveitis? Second is, how do lab tests actually influence your diagnosis? What are the examples of using the concept of pre-test probability? I think this is the word that I would want you to take from this talk. And what do you do if there is a high pre-test probability but the tests are negative? And when do we screen for some diagnosis in uveitis? So these are the 5 points that I'll cover in this talk. If you want more details, these are the 2 very good papers that especially all the residents and younger people sitting here should go through. So why do we investigate in uveitis? As you have seen since morning, most of the diagnoses that we make in uveitis are actually clinical diagnoses. And this especially includes most of the retinitis lesions, the viral anterior uveitis, the Fuchs uveitis syndrome. Then in the non-infectious part also, the white dot syndromes. And when I say clinical, it means what you're seeing during your indirect ophthalmoscopy as well as your imaging findings, or VKH, Behçet's, and to an extent even B27 is a clinical diagnosis. So why do we want to investigate in uveitis? There are 2 important reasons, and if you keep these 2 reasons in mind, you can talk to the patient also in a much better way, because many times the patient will come to you and ask that I've been going to so many people and everybody tells me that we don't know why this happens. Or somebody could have said, you know, it's an autoimmune response, allergy, etc., etc. So just tell the patient that there are 2 things I want to rule out. Do you have an infection or not? Second is there a systemic disease that is behind your eye problem? And these are the 2 exact reasons why we do our tests. Of course, there could be other reasons like checking the immune status, the fitness to therapy, and monitoring the treatment response. But these are secondary reasons. So these are 2 questions that I'm presenting to you. One is, if the disease is present, will the test be positive? And the second is, if the test is positive, is the disease present? Now, which of these 2 questions do you think is relevant for you in the clinic? Right? The second one, right? Because the patient is coming to you not with a diagnosis, but with lab reports. And with those lab reports, you want to know if the disease is present or not. So this concept of what will tell you if the disease is present or not, if the test is positive, is called as positive predictive value. And if the test is negative, it's called as negative predictive value. And this is almost the same as the pretest probability, which is the prevalence of a disease before ordering a test. So the positive predictive value is of the test, and the pretest probability is your clinical judgment before you have ordered the test. So this figure basically tells you that in the middle is when you are like 50-50, the test could be, the disease could be present or not present. And on one side are different grades of, you know, when you're not sure if the disease is present, and on the other side, when you're very sure that the disease is present. So when you're very sure, one is very high prevalence of the disease. You know, TB in our country is one example. The ocular signs are, and this is what I want you to focus on, the ocular signs are very suggestive of a given disease. The patient profile, a good example is HIV, or the immune status suggestive of a particular diagnosis. On the other hand, if there's a low prevalence, birdshot is a good example. In India, we do not see birdshot chorioretinopathy. So low prevalence of the disease, the ocular signs are opposing. You see granulomatous uveitis, you're not going to think of B27 or Behçet. Okay? Then you see the patient profile. All of these things will tell you that the pretest probability is low for a given diagnosis. So this is probably the art of practicing uveitis that you should take from this talk. So how do you convert this pretest probability to a post-test probability? And for this we have a statistical concept called as likelihood ratio, which basically combines the values of sensitivity and specificity. And to explain this, I am using this paper which was published in 2009 about the specificity and sensitivity of the quantiferon TB gold test in the diagnosis of ocular TB. And from there I calculated that the likelihood ratio, the positive likelihood ratio was 3.42 for this test for the diagnosis of ocular TB. Now let's keep this 3.42 in mind, okay. Now this is a chart which you are definitely not going to use in your clinic, but this chart has three columns. The middle column is that of the likelihood ratio, and if we put a red dot where our 3.42 is, now on one side we have the pre-test probability and on the other side we have the post-test. And let's look at three different clinical scenarios. One is a patient with a non-granulomatous anterior uveitis, a history of an inflammatory back pain, and there is no history of TB contact. In this patient, for some reason, you advised the quantiferon TB gold test and it came out to be positive. What does it mean? It still means that your post-test probability is just about 10%. So because your pre-test was so low, just 2%, then these are approximate values. Don't, these are not based on any evidence, but you know that the pre-test is very low. So with such a low pre-test and with the same positive test, your post-test comes out to be still low, and it's not useful for starting anti-TB therapy in this patient. On the other hand, if the patient has intermediate uveitis, which is relatively more common in TB, but no history of TB contact and the TPH and sarcoid have not been tested, still your pre-test is quite low and the post-test is not more than 60%, not good enough to start your anti-TB therapy. Okay, these are everyday clinical scenarios that you come across. Now the third scenario, you have seen so many cases of serpiginous-like choroiditis being present. Now a patient comes with serpiginous-like choroiditis, there is a history of TB contact, your pre-test probability is very high now for TB, around 80%. Now if you connect the dots, your post-test comes to be around 95%, okay. This is the scenario where you definitely treat the patient with anti-TB therapy. Now all these numbers are approximate, don't go by the numbers, it's only to explain the concept of pre-test and post-test probability to you. Okay. The reverse example, two common tests that we advise all the time in our uveitis clinics, ANA and rheumatoid factor. What is the prevalence of, something wrong with the clock there, okay. So what is the prevalence of SLE in isolated uveitis when there is no systemic disease? Less than 1%, same with rheumatoid arthritis. Now if the tests for ANA or rheumatoid arthritis are positive in these patients with isolated uveitis, no other systemic disease, then it really doesn't mean anything because your post-test probability is less than 4.4% for SLE and less than 2.5%. You're not going to treat this patient for either SLE or rheumatoid arthritis. This shows how meaningless it is to test for either of these two in our patients who do not have any systemic SLE or rheumatoid arthritis. Now, what happens, and this again came up many times, you just heard in Dr. Alok Sen's presentation, what happens when you have a very high pre-test probability but your test is negative? You expected it to be positive, but the test is negative. Or you have a very low pre-test probability, non-granulomatous anterior uveitis, but your test is positive, your MON2 is positive. Okay? Then what you do, these concepts are called as false discovery rate or false omission rate, and we come across this all the time in our clinical practice. Okay? You are expecting TB, but your TB tests are negative. Okay? you are expecting B27, but your MON2 or toxo comes out to be positive. When you should not have tested those things, you did test and they turned out to be positive. And these are things that you should be very careful about. When the pre-test probability is either very low or very high, you should be careful about the test. Okay, I will not go through this case now, don't have the time. When do we screen? We screen when a given disease can present with any form of uveitis. There is a need for lab tests for the diagnosis. The test is very good and the treatment is very different from other uveitis entities, and there are only two conditions that fit into all these criteria. These are sarcoid and syphilis. So there is absolutely no other disease for which we should be screening routinely in our uveitis patients. What's the summary? The summary is that the patient is always much more important than the test. The pre-test probability depends on the history, clinical signs, and the prevalence of the disease. We should be careful when the pre-test probability is either very low or very high and the test is not matching it. And there's a very limited role of screening or workup. Thank you for your time.